Hi everyone, and welcome to this live Q&A hosted by the Cleft Lip and Palate Association on the subject of genetics. My name is Tamsin. I'm mum to a 12-year-old boy who was born with a bilateral cleft lip and palate as part of a genetic syndrome of which we don't know the name, so we also call him a swan child, a syndrome without a name. I've been volunteering since he was a baby, so for about 11 years now. And tonight I'm joined by Jen, one of our other lovely Clapper volunteers.
Hello, I'm Jen. As Tamsin said, I'm also a volunteer for Clapper, and I've been volunteering for about 4.5 years. I have a 5-year-old daughter with a bilateral cleft lip and palate, and I'm currently 23 weeks pregnant with another little girl who also has a bilateral cleft lip and presumably palate. And those clefts are both due to an inherited genetic condition called Van der Voode syndrome, which is passed down through my husband's side of the family.
Thank you, Jen. We'd also like to welcome cleft specialists Mark Hamilton and Sarah Lewis, who will be answering your questions this evening. Mark and Sarah, would you like to introduce yourselves? Sarah, why don't you go first?
Yeah. Hello. I'm Sarah Lewis. I'm a professor at the University of Bristol, and I specialise on genetic epidemiology, so looking for genetic causes of disease and conditions such as cleft, and also using genetics to understand more about environmental causes of conditions as well.
My name is Mark Hamilton. I'm a consultant clinical geneticist based in Glasgow. Among a number of other things, I'm the clinical geneticist attached to the Cleft Lip and Palate Service here in the west of Scotland.
Thank you both for joining us today, and thank you to everybody who has submitted a question in advance. If you do have a question while watching, please do pop it in the comments, and someone from Clapper will either respond directly or pass it on to us, and we'll do our very best to answer everyone's questions tonight. However, if there are any we don't get round to answering, we will try and get back to you via the chat feature after the event.
Thanks, Tamsin. That's good to know. We'd also like to say a big thank you to our funders, the National Lottery Community Fund and to Smile Train. And without any further ado, we'll move on to the questions.
Okay then, so what do clinical geneticists do?
Okay, so clinical geneticist is a medical doctor. Our role usually involves diagnosing or trying to diagnose medical conditions that are caused by changes in the body's instructions, so caused by changes in the genetic material of the DNA. Sometimes people think that means it's always an inherited condition, so these can be conditions that run in a family and go back for generations, or they can be a new genetic change in the affected person as well, so it may be that there isn't any family history. I suppose with reference to cleft specifically, we'll probably hear a bit more from Sarah, I imagine. You know, our understanding is that generally speaking, most clefts, our understanding is that they happen for complex reasons. Hereditary factors may play a part, but that can involve lots of little genetic variations, each playing a small part. There may be influences from the environment that we don't fully understand, and perhaps even an element of chance. So for a lot of people with a cleft, actually, there isn't any one single genetic change which is the reason why they've been affected. And actually, the genetic test that we would do in a hospital laboratory may not find any explanation why. But for a minority of people overall with clefts, there may be a specific change in the genetic code that in itself has had a stronger effect. So for some of these less common genetic causes of clefts, sometimes there can be other implications, either for medical care of a child or for a development in that child, or the likelihood of recurrence in future pregnancies. So I suppose and the very tricky role as a geneticist, I suppose, is for us to try to tell the difference and to organise or offer genetic investigations where those are appropriate. So I suppose anyone can ask to speak to a clinical geneticist if they wish as part of their cleft care. Reasons why people often come to see us is either because there is a strong family history, perhaps they're planning another pregnancy and want very individualized advice about the likelihood of recurrence, or in children who've perhaps, in addition to their cleft, been born with maybe other physical differences in development, or there are concerns about a child meeting milestones and there's a question around could this be part of an underlying genetic condition? So sorry, that was a long answer. That helpful?
That's great, thank you, Mark. The next question is, what is the Cleft Collective?
I guess that's my question. So the Cleft Collective is a large study of children who are born with a cleft and their parents. And we started recruiting in 2013. So we're based, the study management team are based in Bristol, but we recruit families all across the UK. We've so far recruited over 3,500 families. And our aim is to collect information from questionnaires and to collect biological samples. And we want to be able to answer three really important questions. One is, what are the causes of cleft? So Mark's already mentioned genetics playing a role, but we don't know everything about the genetics in relation to cleft. And there are also other factors which contribute to risk of cleft. So we want to understand more about that. We also want to be able to answer the question, which is, what are the best treatments for cleft? And finally, how will children born with a cleft fare in the future? So are they going to be okay in the long term? So that's our aim within the Cleft Collective.
Thank you. Our next question is, what is genetic counselling? What is testing for cleft, and how do we access this?
Yes, so I suppose I probably the first of maybe a couple of disclaimers. There's potentially a bit of regional variation, perhaps just reflecting the fact that no one quite knows exactly what's the best way to approach things. There may be a bit of regional variation in terms of exactly what's approach to genetic testing and what's available. So I can again, I'll speak in general terms, but genetic counselling, I suppose that counselling element of a genetics appointment. Maybe it's helpful to say what happens actually at a genetics appointment. So often, if you ask to come and speak to a clinical geneticist, the appointment will involve taking a bit of a history. So usually starting with the person who's affected themselves, a bit of the medical developmental history, drawing out a family tree, asking about clefting and perhaps other, medical issues that we might associate. And then making an examination of the affected person, again, because sometimes there can be little subtle physical clues that a geneticist might pick up on that might point us in a particular direction for genetic investigations. I suppose the counselling element of the appointment is a bit different maybe from the sort of therapeutic counselling that might be offered for things like anxiety. It's counselling around trying to give information and allow or help an individual or family to make the best decisions for them in light of that information. So I suppose in relation to clefting, that might be around what tests we might be able to offer to look into things. If we think, well, first of all, are any tests likely to be helpful? If tests are offered, what are the possible outcomes of that test? One presumably being potentially finding an explanation for things. But acknowledging that many genetic tests, for example, can throw up little findings that are of uncertain significance. Of course, we've all got little variations and differences in our genetic code, and most of that's probably harmless, so you can have uncertain findings. Occasionally, you can even have unexpected incidental findings that have nothing to do with the cleft, but may have other medical significance. So I guess there's a conversation to be had around the decision to embark on testing. When results come back, again, there's, if you like, more of a discussion and counselling around any positive findings, what we think that means in terms of any other implications for the affected person, likelihood of recurrence in a future pregnancy, and also any, in some cases there may be particular options that could be offered to a couple if they're concerned about a particular genetic condition being passed on. So those are the sorts of things that I guess would be covered through genetic counselling. In terms of how you can access this, so there are regional genetic services scattered throughout the UK. Most clinical geneticists, I think, would feel quite comfortable. It would be part of our basic training to learn about genetics of clefting. So you can ask for a referral through your GP. You can ask for a referral through your cleft team usually as well, so the cleft nurse specialist. Waiting lists also probably vary a bit regionally, but often it's important to mention things like in a referral if you are planning a further pregnancy and you're concerned about that, because sometimes that can allow a referral to be treated with a bit more urgency if there's pregnancies and things involved. Yeah. Sorry, another long answer.
No, that's great, thank you. So the next question is, where can we find research and information about other conditions related to cleft?
Any?
Would you like me to go with that? So there are there is some information on the CLAPA website about some of the cleft syndromes. The NHS has databases with information on some information on there. There's a cleft charity called Cleft Bridging the Gap, which has a lot of information about research that's going on. And I think if you're wanting to find out about a particular condition, you could search for information on that condition, but obviously stick to websites that are quite reliable, like the NHS websites and Clapper and places like that. Don't know if you can think of any more, Mark.
I was just going to say, I think the Cleft Collective website is very nice stuff.
Yeah, no, we have a lot of information on our research, but not necessarily on the different syndromes and conditions that are related to cleft.
Yeah, no, you're absolutely right. I mean, there's several hundred different genetic conditions that list clefting as a part. So I think it may, for individuals without a specific diagnosis, I suppose, to go away and try and read about them all could risk being misleading or be difficult. And I suppose the issues and the challenges maybe facing a child, for example, with Stickler syndrome are probably very difficult from those with, for example, DiGeorge syndrome or different things. So yeah, I think although individually rare, they're so vast that maybe it is difficult to suggest one place to read about them all. But part of a genetics consultation, again, might be signposting you to the most appropriate literature for your particular situation, I suppose. Yeah.
That's great, thank you. So our next question is, what genetic conditions are associated with cleft?
All 200. So we could mention, I suppose, a few examples. I've already heard about Van der Waede syndrome mentioned. That's a condition that is inherited in what we would call an autosomal dominant way. So the gene associated with Van der Waede, we have two copies, one from our mum and one from our dad. And each time we have a child, we pass on one or other copy. And having a spelling change, a little change in the genetic code on just one of your two copies is enough to cause symptoms. So for a family affected by Van der Waede syndrome, for the offspring of an affected person, there's a 50% chance each time of the gene change being passed on. But there's a couple of sort of subtleties there, the idea of what they call incomplete penetrance. In other words, not everyone who inherits a gene change will necessarily show symptoms, although a high proportion do. And this concept of variable expressivity as well, and what that means is that of those people who do show symptoms, actually there can be quite a lot of variation. And it's one of the rarer examples of a genetic condition where you can see mixed clefting. So for some people it might be this, for others palate, lip and palate, or combinations. And another little clue that can sometimes alert a doctor is sometimes affected people have what they call little developmental lip pits, little so developmental pits on the bottom lip. So I suppose that's quite a nice example that sort of demonstrates even when you've got a known genetic cause, there can actually still be a lot of variability, and we can still be a bit limited in what we can predict based on a genetic result alone. Maybe another nice example is a condition called Stickler syndrome. So that might be something we think about in children with cleft palate, particularly associated with some underdevelopment of the jawbone, what we call Pierre-Robin sequence. Children with Stickler syndrome, again, it's something that sometimes an experienced doctor can recognise, but again, I guess just by examining a child, but I wouldn't claim to be able to do that every single time. Association with Stickler syndrome can include a tendency to short-sightedness affecting the eyes, and that can be associated over a person's lifetime with an increased chance of retinal detachment that can affect vision. But with good follow-up, there are preventative treatments and things that can be implemented. So if we know a child has Stickler syndrome, then we can implement the right follow-up for their eyes, and sometimes sort of laxity of a bit of joint laxity can be a feature as well. So that, I suppose, that would be another example where knowing a diagnosis might slightly change a person's medical care. There's a great big list in genes still being discovered for various developmental conditions, so where cleft might be associated with an increased chance of either other physical differences in development, like congenital heart anomalies, for example, or other physical differences, or developmental delays and learning disabilities. I guess another commoner example would be something called 22q11 deletion or DiGeorge syndrome. That involves the loss of a little portion of genetic material from one of a child's copies of chromosome 22. Again, sometimes that can be picked up because a child also may be born with congenital heart anomalies, or sometimes it's actually a condition that's sometimes picked up by our speech and language therapy colleagues in older children, where there are maybe concerns about speech development that seem more than they would expect just from the cleft alone. And then just a great big list of individually rare things with or without other associations. Yeah, anything you would add to that, Sarah?
No, I think that's quite comprehensive, but as you said, there's over 200 syndromes, so yeah, we may not have covered everything.
No, that's great. Thank you very much. We've just had a question come in from someone who's watching the live stream, so I'm just going to add that question in before we carry on with the pre-submitted questions. So this question is, my son was born in 2020 with a cleft palate, and we were told Pierre-Robin syndrome, although it's never been formally diagnosed. My son is the 4th generation of his dad's side, all men, to have the exact same cleft palate. I was disappointed at the lack of interest in exploring his genetics from his perspective. We had a blood test and received a follow-up letter which made no sense, and that was it. Not a specific question, but maybe just them exploring around what else might be able to be offered in that situation, perhaps.
Yeah. So, sorry to hear about a disappointing experience. Certainly 4 generations in a family does sound more suggestive of a single genetic change with a strong effect rather than a sort of complex cause. I suppose I'd be interested to know is short-sightedness and eye features. That might be part of a sort of an assessment a doctor would do. I probably should say my second little disclaimer of the night. Obviously, I think I'm anticipating there may be a lot of questions about people's individual medical situations. Obviously, I can talk in general terms about things, but clearly without a family in front of me and medical records and things, I risk saying the wrong thing, and obviously, questions should be directed back towards your local service. But I suppose, yes, so that story clearly sounds very suggestive of a single genetic change in the family having a strong effect. The breadth of genetic tests available does broaden with time, so we certainly don't always find an answer, even for children. I mean, your Tamsin's alluded to that also, children in whom we strongly suspect that there must be a genetic explanation for things. We don't always find that, and that can be due to technical limitations of the test, not being able to find everything even in genes that we know about, as well as the likelihood that there are still new genes yet to be discovered. In those situations, we can still give, if you like, empirical risk, advice based on the information that we have. And in that situation, I suppose, sounds very like one of these dominant conditions where there may be a 50% chance of the trait being passed on. But the breadth of genetic testing available has exploded a bit in recent years, and probably staffing hasn't caught up with that yet. But the breadth of testing available is likely to continue to widen with time. So I suppose maybe the general point is, even for those individuals who haven't had an answer in their first contact with genetic services, I think it's always reasonable to check in again in a few years' time. Have there been any advances? Are there any tests that you could offer us now that weren't available when we were last seen? And often, almost for everyone I see in my clinic, I do say, particularly for children, they might like to come back and see us when they're young adults themselves, because I'm sure it will all be different then. And particularly through Sarah's work, even our understanding, even where there isn't a genetic cause, but things are more complex, perhaps in time we'll be able to understand all that a bit better and give more individualized advice. So yes, so I'm sorry to hear about that experience, but definitely things change over time. So checking in again in the future isn't an unreasonable thing to do, because it may be that the breadth of testing available has widened. Yeah.
That's great. Thank you for that.
But we don't get a result for everyone. That's even when we try our hardest and throw the kitchen sink at things. So that's just the nature of things. Yeah.
Brilliant. Thank you. Just go back to the pre-submitted list, and the next one is it possible to find out whether a cleft is genetic? My son has a cleft, but my mum is adopted, so we're not sure whether there is a history of cleft in our family. We're interested to know so that we can be prepared for if he'd like to have children.
Yes. So if I understand correctly, that's one affected child in a family. The question doesn't say which type of cleft. I mean, I suppose our thinking from a genetic perspective is maybe slightly different according to different types of tests. That's an interesting point. So, yeah, I guess as part of building a complete picture, we like to take a family tree where that's possible and know as much about the family history. Clearly, in this case, because of adoption, that's not possible, but that's still not an impediment to to us having a look and I think about things. So again, with a single cleft in a family in a child who otherwise doesn't seem to have any unusual medical or developmental problems, our assumption would be most likely that's an isolated non-syndromic cleft. Clearly, to say that for sure, I would like to see the child. So you've got those questions, do seek a referral. I think it would be, so for an isolated non-syndromic cleft where we assume that the cause has been this sort of multifactorial combination of things, for the offspring of that person, our first estimation would be that the likelihood of clefting is a bit higher than the general population. So if we take general population figure of about 1 in 700. Again, there's different figures based on different studies. I've tended to use, there was a big Danish study that looked at several thousand families. You might see different figures, but it's usually estimated in the order of a few percent, maybe somewhere between 2 to 4%, that sort of range. But I think if you have that question, if you're concerned, so the parents of the affected child, if you've concerned yourself about future children you might have, then you may want to ask to see a geneticist now. If your question's more around that child and growing up, you would still be welcome to ask for a referral to speak to a geneticist, but failing that, if things aren't if it's not going to change anything in the short term, then maybe the suggestion is for that child when they're a young adult to come and see us, because again, my expectation would be that our understanding the breadth of tests available would be wider. I don't know, I've not said anything terribly wrong there, have I, Sarah?
Brilliant. We've had another comment come in. So just before we move on to our next question, this comment says, I have a cleft and so does my son. We had testing and was told it was just predisposition in family. After checking family, I found my great uncle died at 4 months from a cleft in 1916. Strange, there's been no others since then until me. Yeah. It was just a comment, if you can elaborate on that.
Speak a wee bit to that. I don't know, do you have anything you want to say about that? So I think you're muted, Sarah.
You're on mute, Sarah.
Sorry. No, I guess probably you can say more about that than me.
That's all right. So that's interesting. Again, you know, I suppose for the reasons that we've talked about, having had genetic testing and not having found an answer, there's a number of possible reasons for that. It may be that there is a single gene change having a big effect, but for various reasons that the test hasn't picked up on it. I suppose with a family history like that, I mean, it sounds as though that's a great uncle. I'd have to draw that out. That's a relatively distant relative, and then lots of people unaffected, and then 2 in a row. I suppose it comes back to this idea of, I suppose one possible explanation for that, among others, is, you know, it sounds as though that may have been the interpretation as this idea of predisposition. So I suppose in some cases, in some families, the genetic change has there's a causative genetic change with a very strong effect. In other words, everyone who inherits has a very high chance of expressing that in some way by having a cleft. At the other end of the scale, it's just a complex mix, maybe lots of little genetic variations feeding into that sort of complex picture. It's likely that there probably are genetic changes that can sit in the middle somewhere that maybe give you a much higher than the general population chance of having a cleft, but you know, but still, because I guess certainly in hospital laboratories, which is probably a distinction between the tests that are done in a hospital laboratory from those that are done on a research basis, often research studies are seeking to understand that more complex picture of things. In the hospital laboratory, I suppose we are more looking for those rare genetic changes with a big effect rather than those common things that feed into the complex picture. And so actually our laboratory will not report genetic variations that are more common or that are just thought to be part of a complex picture, because in a medical sense, they're not particularly helpful. They don't, based on our current understanding, we're not able to predict much about the future. We're not able to predict, you know, say offer you a test in a pregnancy and tell you what's the chance of the baby being affected. If it's something of a lower effect, then the hospital laboratory will tend not to report those. So I suppose that's one possible explanation, is that there may be something having a more intermediate effect in your family rather than a strong effect. But the other possibility is that there is a genetic change having a strong effect, but the limitations of the tests available, we've just not found it. So yeah, I think a bit of an uncertain situation. Maybe not a very good explanation.
Thank you, Mark. Thank you. Back to our pre-submitted questions. My siblings were born with minor dental issues, an extra tooth or two, and small jaw for all their teeth. My daughters both have misaligned teeth. Could genetics that caused my cleft lip and palate be influencing them? There's been no other cleft lip or palate identified in the family.
Shall I have a go at that one? Yeah. So yeah, we are starting to realize that there are genes which cause cleft that are also related to facial development in the general population. So, for example, we found genes which are related to philtrum width, which is this bit of this indent in the top lip here. Genes that affect the width of that philtrum in the general population are also related to cleft. So, and obviously, genes which are related to the size of the jaw are also related to cleft, because we have syndrome, Pierre-Robin syndrome, which has already been talked about, which for which children present with a small jaw and they have a cleft. So we know that there are genes that affect both. So we're starting to understand that there are genes which affect lots of features within the face and also contribute to cleft, and they may be manifest differently in different family members, but the research around this is still quite novel, so we haven't fully worked it all out yet. Yeah, I don't know if you want to add anything, Mark.
No, I think I agree that I did cover it. There's a wee tiny bit in the literature about sort of missing or extra teeth or hypodontia and things, isn't there, and close relatives. So I think it's, it's hard to say funny teeth are common enough in the general population. So it's difficult to say, but definitely plausible that it could be some reflection of the genetic background. Absolutely, yep. But probably not particularly, I guess, again, that distinction between research and the hospital, it's probably not something that would strike me as particularly useful in identifying a particular genetic cause or syndrome or condition. But yeah, plausible that it could be related, yep.
Thank you. The next question, it doesn't specifically say, but I think this is from parents who already have a child with a cleft. It doesn't say what type of cleft, but the question is, if we were to have another child, what are the chances of them being affected? No testing has been done and there is no known family history.
Yes. So again, there are, if you like, these empirical figures, these things that come from big population studies of looking at many families. I suppose they assume that the cleft is a kind of an isolated thing in a child with no other features to suggest one of these underlying genetic causes that we've spoken about. And in that scenario, yes, compared to a background incidence in the order of about 1 in 700, the figures that I've tended to quote, and you may be able to find slight differences elsewhere, are maybe around the order of 2 to 3% for a cleft lip, sort of 3 to 4% for a cleft palate. Again, figures vary, but generally in the order of a few percent. I think if the possibility of recurrence is something that that is a real concern for you, then it wouldn't be unreasonable to ask for an appointment, sort of pre-consent. And I guess if there are questions about a pregnancy, it's always best that those questions are asked before a pregnancy is in progress. But we realise that's things don't always work out like that. But it would be it would be reasonable to ask to speak to a geneticist for an individualised assessment of your situation and examination of the affected child, drawing the family tree as a matter of routine. And actually, that maybe goes back to a previous question. I often ask to look at the the palates and the lower lips of parents. Again, just looking for any of these sort of evidence of a more subtle anomaly, just in case that slightly influences what we see. So yes, the empirical, the sort of overall guesstimate is slightly increased compared to the general population, but overall low. But there can be rarer scenarios where there is there is an underlying genetic cause, and so if that's something you're concerned about, then very reasonable to ask to speak to a geneticist.
Thank you very much. Okay, our next question, it's quite a long one. I would like more information about the heritability of cleft. I was born with a cleft lip and partial cleft palate. Neither of my parents had a cleft. My husband does not have a cleft, and our son was born with no similar issues. What are the probabilities that his children assuming his partner does not have a cleft, would be at greater risk of cleft than average?
Okay.
Okay.
I think I've got.
You've got it?
Yeah.
Got the family tree there.
So yes, so one person affected in this family, her son has no cleft. So the question is, what are the risk of his children? So again, if we are, usual disclaimers, it'd be nice to see you. But if we assume that again, this is so one cleft in the family and someone who the implication is otherwise well, so most likely not, if you like, a syndromic cleft, a cleft due to an underlying genetic condition, most likely to have a kind of complex cause. Again, the data would suggest that, so for that person's immediate relatives, so for that individual having children, there would be that sort of few percent increased risk. The suggestion is that for clefts with a sort of complex cause, the risk falls off quite quickly as you move away from that individual in a family. So I guess for the child of a person who themselves doesn't have any symptoms, I might say it's still fractionally increased compared to the general population, but probably only very marginally. I think that Danish paper, Sarah might be more familiar with it. I think it might even suggest it's less than 1%. Is that right? But still a bit.
Yeah, just a tiny increase, as you said, compared to the general population. But yeah.
But again, we're assuming certain things. So if it's something you consider, and actually that raises an important point. Actually, if you are considering seeking a genetics appointment, it's most useful for the person who themselves is affected, is referred. So in other words, it's not usually as helpful to see a healthy person with no history of clefting who's concerned about the family history of clefting. Actually, who we would like to meet is the person who had the cleft, if that makes sense. Because if we were doing any genetic investigations, it makes most sense to start with the person who actually has the thing that we're concerned about. So for this family, if they were seeking advice, it would be the affected person rather than the healthy son that would usefully come to speak to us. But in the face of things, that seems like a low risk scenario, I would say.
Brilliant, thank you. Just a comment that's come in. So I was born with Van der Voodie. My mum has it too, and we're starting to think about going down genetic testing in terms of wanting to start a family. It does feel a bit of a minefield, so this is a really helpful chat. Thank you. So, just a comment there from somebody.
So definitely, absolutely. Would encourage that, and I guess just to acknowledge. So it's a very personal thing how concerned or not concerned people, particularly with Van der Voodie, are about passing on the condition of this cleft in the child with the cleft. But there can, for those who are very concerned, there can be options around approaching a pregnancy if a genetic cause is known and there's thought to be a substantial chance for pregnancy being affected. That those can be options like pre-implantation genetic diagnosis, so a process similar to IVF, but with the added step of genetic testing. So again, very personal whether that's something people want to pursue. There are certain criteria that have to be met to determine whether those sorts of things can be offered in the NHS. But I guess just to acknowledge that it's, if you have questions about those kinds of things and you want to have all the information before you go on to start your family, then definitely that would be a very reasonable referral for us to receive, and we'd be happy to see someone with that story. Yeah.
Thank you. So the next question, should everyone with a cleft get genetic testing, even if it is just to confirm that the cleft is isolated, and is there a downside to getting genetic testing?
That's a good question. So should everyone, again, I think this is potentially something that, where practice likely varies because there aren't established guidelines. Actually, a piece of good news is that I've recently been invited to join what they're calling a clinical excellence network. So they're trying to make a network of geneticists in the UK that see people with clefts, I guess with a view to making some standardized recommendations, because I suspect that there probably is a bit of variation in practice. So that will be a useful thing. In certain scenarios, so for example, isolated cleft lip with no family history and no other health concerns, I suppose the likelihood of finding a genetic change with extensive is extremely low in that situation. Never zero, but it's very, yeah, it would be extremely low in that situation. And when we do genetic tests, even I guess a basic first line test is often a detailed chromosome test, a chromosome microarray that looks at the packages of genetic material. The modern tests are quite sensitive, so they can find little variations in the genetic codes. It's not uncommon to find little variations where we're actually unsure what they mean. They're of uncertain significance. Can't say if they're of any medical significance, or they're just part of harmless genetic variation. There are some small chromosome variations that, for example, crop up more commonly in people with autism spectrum disorders, but are also there in the general population. So it doesn't sort of predict anything in particular, but can raise worry. So are there downsides? Yeah, we can get uncertain results. We can get sort of unexpected incidental information that either does have medical implications or has uncertain implications, but can raise worries. So I think it is a considered decision, particularly in those scenarios, where the family history in the examination doesn't seem particularly suspicious of an underlying genetic cause. So yeah, not everyone who comes to see me walks away with any genetic test being done, usually it's a bit of a considered conversation, and that maybe is part of the genetic counselling of what do I think is the likelihood of us finding something useful versus the likelihood of potentially uncertain and muddying the water and causing you more worry without being helpful. And that's perhaps different in different scenarios. Yeah, that makes sense. So yeah, again, just to reiterate, I suppose the people I would more strongly urge to come and see is those with a positive family history. Even if you don't have a positive family history, a child that maybe has other physical differences in development or unusual medical problems, and there's a question, is there something to tie it all together? Children where there are delays in meeting developmental milestones that wouldn't be just explained by, understandably, clefts can impact on speech and there can be hearing issues, but if there's developmental concerns that aren't really explained by that, or what else? Yeah, I think those would be the main. And I guess, generally, particularly cleft with PR or band sequence, I would usually have quite a low threshold just to do some basic genetic tests and exclude a few potential causes. But yeah, in all scenarios, the most common outcome is that we don't find an answer. And also, yeah, again, that uncertainty. So using genetic tests to rule things out is a little bit tricky, because occasionally you get these uncertain findings and you confuse things even more rather than ruling things out. Yeah, I don't know if that's helpful.
Thank you. Okay, our next question. My sister and brother both born with cleft lip and palates, one bilateral, including palate, and one just lip. My son has been born with a unilateral cleft lip and palate. Surely this is genetic and not a coincidence. Can someone be tested? And are there earlier signs than just a 20-week scan?
Yep, so again, a family tree that seems to suggest a big genetic contribution. Again, whether or not that would be something that we would pick up with the tests available in the hospital is uncertain, but I think very reasonable to ask the question, to come and see someone. The implication with the family history here again is that there's a brother and sister, but the person themselves wasn't affected, but then their child was. Always possible that things might be unrelated, but seems more likely that there is a connection. So can someone be tested? Yep. And again, I guess that point that it's most useful to start with someone who is themselves affected. asking for a referral. And actually, it can be useful to have more than one affected person in a family, because if, for example, we get one of these uncertain findings, actually sometimes testing other people, so both affected and unaffected, can sometimes help to clarify whether that looks like it is the cause or not. So that it can be useful to have a number of people, and if everyone's sort of happy to be open and consent for their samples to be used and the medical information to be gathered by the geneticist, that's another part of our role, is tying together different people in the family. So I think, yeah, well worth asking to see a geneticist. Are there earlier signs than just a 20-week scan? That's another good question. Usually, so I'm speaking slightly on behalf of obstetricians and fetal medicine people, so again, individual practices and local approaches might vary. But often, if you have a history of a congenital difference in development, like a cleft in a previous child, often you are offered some additional scanning in a pregnancy. It's likely that, I suppose, a cleft is probably there from, involving the lip, would be there from about 7 or 8 weeks of gestation. Whether or not, I'm actually not sure when an obstetrician would feel confident that they could see that on a scan. Often they're picked up at a 20-week scan, because that's when in the general population an anomaly scan is done. I suppose important to make the point that clefts involving the lip are often picked up antenatally at that anomaly scan. That's much less common for a cleft involving just a cleft palate to be picked up antenatally. In situations where it's associated with some underdevelopment of the jaw, so sort of Pierre Robin picture, that might be something that the sonographer would comment on, is the small chin. And sometimes there can be a sort of mechanical issue with baby swallowing the amniotic fluid, so a sort of higher level of amniotic fluid, polyhydramnios, sometimes can be something. But so yes, my expectation, but it's not possible to speak on behalf of obstetricians, would be that having had a previous child with a cleft, you would be offered some additional scanning. I'm not sure how quickly, how early they might be able to see that. And yes, clefts involving the lip are much more likely to be diagnosed antenatally than those just involving the palate. But yeah, occasionally they can be, particularly if there's the Pierre Robin features as well. Yep. That helps.
Thank you. Just to add to that, actually, because our daughter has got a cleft already, we were offered an early scan. So for this pregnancy, this baby's cleft was picked up at 16 weeks. They didn't see it on the 12-week scan, but the sonographer did say that occasionally they can pick it up from the 13-week scan in some places. So, yeah. So just two parts to this question that's coming from the live stream, actually. But when can you go down the genetic route, and how do you go about getting those genetic tests?
Yeah, so I mean, certainly locally here, anyone can ask. I guess for the reasons that I've talked about, there are certain scenarios, the family history, the other medical features. There are certain things that might highlight a family of there being a greater chance of there being a genetic cause for things. But really, anyone that's got questions about the genetic side of things can ask for a referral. And I don't think a local genetic service would decline a referral from anyone who wanted to, come and have that individualized assessment, the examination of the affected person, taking the history, the drawing the family tree. It may be that the conclusion of that is this looks like an isolated non-syndromic thing. The doctor's recommendation may be that actually I don't think there's likely to be much use in offering any genetic testing. So the outcome may be that actually the advice is that genetic testing isn't likely to be useful, or it may be that some basic or targeted or broader tests are offered depending on the scenario. But really, anyone, if they've got those questions or concerns, you can ask to see a geneticist, but particularly for clefts involving the lip with an otherwise wheelchair and apparently isolated thing, probably the likelihood of finding a genetic cause is very low. But if those questions are there, I think it's questions or concerns, then usually geneticists are happy to see people for sort of individualized assessment.
Thank you very much. Right, our next question. Our little girl is 10 weeks old, so congratulations. She was diagnosed with a cleft palate at birth. She also has Pierre-Robin sequence. We have no family history of cleft on either side, and it was not picked up antenatally. We are wondering about the possibility of any further children having a cleft too. How likely is this? And could we do any testing or similar to understand more?
Yeah, so again, I think that would be a very reasonable request to come and see a geneticist. So Pierre-Robin, like all other causes of cleft, certainly probably in the order of at least half. We don't know why it happens. The causes are probably complex, but there can be genetic associations, for example, like the genes that we've talked about in relation to condition Stickler syndrome. Again, it would be my own practice for a child with Pierre-Robin sequence to offer some basic genetic investigations just to make certain specific genetic causes as likely as, or to exclude things as far as possible. So I think, that would be another scenario where it's extremely reasonable to ask to see your local genetic service. It's likely that some basic genetic investigations at least would be offered. Again, it's all in the, in the context of examination of parents, a family tree. It sounds like it's an isolated thing. Again, the conclusion may be that in the absence of any identifiable genetic cause, in the absence of any suggestive family history, we're back to that, marginally increased compared to the general population, but overall low chance of recurrence. But that would certainly be a situation where I think, to give more definite, I'd want to see the child myself, and I'd want to go through a bit of history and examination and family tree. Yes, so I would encourage, if that's particularly if future pregnancies are a concern, I would encourage you to take that forward if you wish.
Thank you, Mark. So we've had another comment come in, coming towards the end of our evening. This one is lovely, actually. It says, more of a comment, but grateful to our cleft team who referred us to genetics. We were enrolled on the DDD study, Deciphering Developmental Disorders study. After several years on the study, my son's SMC3 gene was found. So they're very grateful. Thank you.
So I think that speaks to this idea that our understanding of all of these things does evolve with times. The DDD study was particularly, for children in whom we suspected the developmental conditions. So I suppose there would have been other features in addition to the cleft that would have led to that enrollment in that particular study. But understanding broadens with time. It can be a long road to diagnosis, for those children with a more complex picture. But yes, that's really nice to hear. And so and again, back to the earlier question of, even if there's a strong suspicion of a genetic issue and you don't get an answer in the first contact with your genetics clinic. I mean, when I say things are evolving all the time, it's usually measured in months and years rather than weeks. But checking in again periodically is always a reasonable thing to do, and certainly a good time to catch children is often as young adults, sort of older teenagers, as they're just before they go off out into the world. That can be a good time just to check in, and when they're old enough and mature enough to ask their own questions about things, that's often a good time.
we've just had another question come in, which I think we've just got a little bit of time left to answer, if that's okay. So the question is, I have 2 boys with cleft and there is no known history in either side of the family having cleft. But my grandmother had a child with spina bifida. My dad has curvature of the spine and I suffer with degenerative discs. Could this be a link? And actually another question from someone else who's coming along the same lines. Can you tell if degenerative disc disease is part of having a cleft that's been recently diagnosed?
Anything you want to say before I dive in, Sarah?
Well, I guess I would just say that this is an area that we are looking at whether some of these things could be linked genetically, but it's quite a new area, and I would, from my knowledge, these things aren't necessarily linked. Yeah.
So okay, I'd agree, but particularly spina bifida, I wouldn't make an obvious connection between those things. I guess acknowledging, and that's not having any of the details of things in front of me. We mentioned one of the genetic causes of clefting, one thing in that list of many as being this condition, Stickler syndrome. That is a condition where people can be a bit more prone to wear, and it's caused by changes in genes involved in making the sort of body's connective tissue collagens. So people with that particular condition can be a bit more prone to wear and tear changes affecting the joints. Again, it doesn't sound strongly suggestive of that to me, but I guess that's the only potential connection that I can make in my mind. But with that story, 2 siblings affected by clefting, again, that would be a reasonable basis to ask a geneticist to cast an eye over things. And part of the reason for taking the family history is sometimes there are little things that may not immediately strike you as being connected, but that might make a light bulb go off in a geneticist's head. But it's not something I would immediately tie together. I think it's much more likely that it's not related. Yeah, hard to say.
Thank you ever so much. I'm afraid that's all we have time for tonight. If you would like to provide us with any feedback, then Clapper would be very grateful, and there will be a link to feedback in the chat.
So just time for some thank you. So firstly, thank you so much to Mark and Sarah for giving up your time to talk to us tonight. It's hugely appreciated, and I'm sure everyone watching feels the same way as well. Thank you as well to everyone who's joined us online. This video will be available on Clapper's Facebook page straight away, and a subtitled version will be posted onto the Clapper YouTube page as soon as possible. So do look out for those if you want to re-watch anything from this evening. And of course, a big thank you to Tamsin for taking time out to volunteer and to host this evening.
And thank you to you as well, Jen, and for all the volunteering and hosting tonight. It's been a fascinating evening. Thank you. And if we didn't get round to answering your questions in the chat, remember you can get in touch at any time at info@clapper.com, where Clapper staff will point you into the right direction. Once again, thank you to Mark and Sarah for joining us, and everyone watching both now and later on. We hope you've enjoyed the Q&A, and we'll see you again at one of our upcoming online events in the future. From all of us, good night and have a lovely rest of the week. Thank you.